good evening. Thanks, Fu, for the kind presentation. Thanks to Topcon staff for the kind invitation. It's a pleasure for me to be here. First time in Singapore. It's a beautiful city. And it's a pleasure for me to talk about a new topic that is treating dry AMD with the new Espansione highlight system. I am a professor in Cagliari. It is an island in the south of Corsica in Italy. And it's a pleasure for me also to talk about a product that is predicted in Italy. It was developed in Italy by an Italian company called Espansione. I collaborate with this company since several years, and I will show the history of our collaboration. When I looked at the topic of this Congress, I read Transforming Retinal Disease Management with Technology, and I think that this topic is perfectly focused on the aim of my talk. And I would substitute technology with highlight, and I will try to show you what kind of efficacy we can reach with this treatment. So, as I will tell you a history describing how this technology has been used in the last years in various settings of ocular diseases. So we started a few years ago using low-level light therapy combined with intense pulsed light for the treatment of dry eye disease. Since then, we tried to compare the efficacy of low-level light therapy versus intense pulsed light for dry eye disease in order to understand which technique was most effective. And then we started studying this technology not only in the office but also at home with the possibility of a new portable tool. Then we moved from dry eye treatment to dry eye prophylaxis. And in the last month, we moved beyond the ocular surface, reaching the retina with dry AMD and other indications. So the first years of study were focused on the combined use of low-level light therapy and intense pulsed light for the treatment of dry eye disease. With these technologies combined, we can find a lot of papers published on PubMed that confirm that this combined use is effective for chronic meibomian gland dysfunction for dry eye disease. But what our group did for the first time was to compare intense pulsed light with low-level light therapy in order to understand which was the most effective treatment and technique between these two techniques. And we, in this randomized control comparative study, comparing 20 patients with the dry eye treated with low-level light therapy and 20 patients with the dry eye treated with intense pulsed light, we showed that low-level light therapy was more effective, providing lower ocular discomfort symptom and higher tear production compared to intense pulsed light. So we can state that you can use low-level light therapy both alone and combined with intense pulsed light to treat dry eye. When use the combined treatment, we recommend to combine low-level light therapy and intense pulsed light in the setting of dry eye owing to ocular rosacea. In the other cases, you can proceed with only low-level light therapy, obtaining excellent result and a very high tolerability of the procedure. Then we moved from office treatment to home treatment. In this paper, we showed how it's possible to treat patients at home. So patients were treated for 1 week, every 2 days, for a total of 4 sessions of low-level light therapy in 1 week. And this serial session of at-home treatments were able to improve tear film production and stability and reduce ocular discomfort symptoms. So you can treat also patients at home with the portable disease, enhancing treatment compliance. In the last year, we moved from dry eye treatment to dry eye prophylaxis. We published on British Journal of Ophthalmology a few months ago the results of the outcomes of low-level light therapy performed 1 week before and 1 week after cataract surgery for the prophylaxis of postoperative dry eye. This is a prospective, randomized, double-masked controlled clinical trial, enrolled more than 150 patients who were randomized to low-level light therapy or to sham treatment. So patients who received the mask session one week before and 1 week after cataract surgery had an improvement of ocular symptoms and an improvement of tear stability, despite surgery. So we were able to counteract the detrimental effect of surgery by treating a patient prophylactically. They were healthy patients with a healthy ocular surface and received the treatment just to avoid the postoperative complication of a dry eye. But let's move to the retina and go beyond the ocular surface. And let's talk about dry age-related macular degeneration. We know that age-related macular degeneration is the leading cause of irreversible blindness in the developed world, and the numbers are huge. We know that the dry type accounts for about 90% of the total cases, with a prevalence of 0.44%, and this prevalence increases with age. We can hypothesize that by 2040, more than 280 million people will be affected by AMD. So the risk factors are well known. So we have age, genetics, race, behavior, obesity, cardiovascular disease, nutrition deficiency, and so on. But which are the more important feature in the retina? So we know that we can see the drusen, that are extracellular deposits, and the subretinal deposits of lipids and proteins beneath the retinal pigment epithelium, and you can see also variable amounts of clumps of pigment in the macula. So usually in the intermediate stage, the drusen become larger and the pigmentary change become more severe. So in the late stage, the disease evolved towards a geographic atrophy that is associated with the degeneration of photoreceptors and retinal pigment epithelium. But what is very important? We know from the literature data that drusen volume is linked to the risk of progression of AMD. So we know that, and several studies demonstrated that eyes that developed geographic atrophy or wet AMD had baseline drusen volumes significantly larger than eyes that did not develop late AMD. And we know that if drusen volume is higher than 0.03 cubic millimeter, had a four-fold risk to develop later AMD. So we should treat this drusen because we know that if the drusen becomes larger, the risk of progression of the AMD increases. But although significant advances have been reached for wet AMD, we can imagine the world around intravitreal injection, therapies for dry AMD have not yet progressed, either as quickly or to an extent comparable. So at the moment, no universal treatments have been identified for dry AMD. We know that we can focus on reduction of risk factor. We can focus on dietary supplements. There are new approaches, mainly focused on inhibitors of the complement, on gene therapy, on cell-based therapies, but so far, no treatments have been proven to effectively prevent the onset of geographic atrophy or to halt the enlargement of the lesion. We know that if we prescribe RX or RX2 supplements, we can reduce the risk, but they do not prevent the onset, or like omega-3. And there are also some contraindications for some kinds of patients. What is there anything else in this field? I would like to tell you about this new technology. It is called photobiomodulation, or low-level light therapy, and it involves the use of selective wavelengths of visible light up to near-infrared light that can be produced by laser or a light source like a diodes. The light is able to elicit mitochondrial light absorption, and it uses cell photoactivation, and it determines cell changes in protein expression. So photobiomodulation increases the availability of electrons to COX, resulting in enhanced cellular metabolism and upregulation of ATP and cAMP. So let's go in detail in the mechanism of action. So this is the first step of the action of the light. So the initial photoabsorption event occurs in the mitochondria, and the principal molecules that absorb the light is the enzyme called cytochrome C oxidase. When cells are damaged by disease or aging, the mitochondria within the cells produce excess nitric oxide, which inhibits electron transport within mitochondria and decrease mitochondrial membrane potential. Light absorption triggers the photodissociation of ANO from cytochrome C oxidase, facilitating its release. Given that nitroxyoxygen plays a role in inhibition the electron transport, photobiomodulation action leads to an increase in mitochondrial membrane potential, oxygen consumption, and the proton gradient, culminating in boost ATP production. Photobiomodulation also reduces oxidative stress and inflammation, and modulates cell signaling and gene expression. So this is another slide that summarizes all the actions that we saw before, and you can see that we can use different types of lights: the yellow light and the red light. The yellow light is able to inhibit the expression of vascular endothelial growth factor, that we know stimulates the formation of blood vessels, while the red light is mainly focused on ATP stimulus and production. Let's see this video. This short video is focused on the mechanism of action that we mentioned before. So this is the mask put in the face of the patient, and we can say how the technology acts at the cellular level. We work at the biological level within the cells. These are the mitochondria that are activated by the light. The cytochrome C oxidase absorbs the light. And we know that specific wavelengths increase this enzyme. The ATP is stimulated. This is a carrier in cells. This improves cellular respiration and metabolism. All these parameters led to sustained and improved cellular function. In the years, we published several papers, mainly focused on the ocular surface, because the technology was first used in that field, but now we are moving to the retina. And which kind of patient we treat with dry AMD? We treat the patient with early and intermediate AMD because we want to stop the progression to late AMD. This is how the mechanism of action of photobiomodulation acts in retinal disease. And I will show you now the data of a double-masked, randomized, controlled, multicenter clinical trial that is currently ongoing. We are enrolling patients with dry AMD, RX2 and RX3 stage of the disease. We currently enrolled more than 100 patients that were treated with the technology and 100 patients that acted as a control. And we are evaluating best corrected visual acuity, anatomical progression of drusen, contrast sensitivity, and quality of life. These are the 7 centers involved, 4 centers in Italy, 1 in France, and 2 in Turkey. And these are the inclusion and exclusion criteria. As said before, we are focused on dry AMD, RX2, RX3, and with best corrected visual acuity in ETDRS higher than 60 letters. This is very important. This is the protocol of use of low-level light therapy in dry AMD. So we have 2 phases of treatment, the phase 1 and phase 2. Phase 1 is made with the yellow light. Yellow light is delivered in a continuous way for 5 minutes with closed eye, and then in a pulsed way, 1 minute with eyes opened. This is the first phase. Immediately after the first phase, we have the second phase that is delivered with a continuous red light for 5 minutes with eye closed, and followed by a pulsed red light for 1 minute with eyes opened. So both phases last together 12 minutes. And this is 1 session of low-level light therapy. Usually, to conclude 1 cycle of treatment, we do 2 sessions per week for 4 weeks. So 8 sessions in total. This is the first cycle of photobiomodulation for dry AMD. The effect usually lasts for 4 to 6 months. After, you can do a second cycle of treatment that is like before, so 2 sessions per week, but for 3 weeks and not for 4 weeks. So 6 sessions in total and not 8 sessions like in the first cycle. These are all the data that we are collecting in the clinical trial. But let's move to the preliminary results. We already analyzed the data from patients after the first cycle of treatment, after 8 sessions of treatment, and we published this result a few months ago. So let's enter in detail on the results. These are the baseline characteristics of patients for the sham group and the photobiomodulation group. Of course, due to the randomization nature, there are no differences in both groups. And the first point that is very important. All patients that received the treatment were fully compliant and were able to complete the entire cycle of 8 sessions without any issue related to the tolerability or the safety of the procedure. These are the main results of this study. So this is a preliminary analysis. We included 76 patients and 152 eyes, 7 centers, with a 6 months follow-up. As you can see, best corrected visual acuity improved in the group treated with photobiomodulation in a statistical significant way, while you can see in the sham group, visual acuity decreased. Okay, this is the natural history of dry AMD, of course. While let's talk about mean drusen volume changes. We can see that in the PBM group, the change was the volume reduced significantly after the first cycle of treatment, while the volume increased in the sham-treated patient. So we were able to reverse the natural history of the disease. But let's focus on some representative cases that can provide you an immediate feeling of the treatment. This is the first case. So it is a 60-year-old female, RH3 category. And at baseline, best corrected visual acuity was 50 letters. Patient underwent a cycle of photobiomodulation, and this is the results. So 1 month after the end of the first session, patient had a gain of 5 letters on ATDRS, and there was also a resolution of certain drusen. Let's see here, up baseline, and in the bottom, after 4 months, you can see this is the same scan on OCT. You can see how this large drusen disappeared. Okay? This is another scan. You can see another drusen, large drusen that disappeared. And the same patient, other scans, you can see how these intermediate drusen disappear or very markedly reduced. There is another case, a representative case. This is another patient. 3 months after the end of the first session, there was an improvement of 4 letters on ATDRS and a complete resolution of some drusen. You can see up in the upper slide the baseline characteristic of the OCT, and in the bottom how this drusen markedly reduced in the volume. But what is next? The next scenario concerns the chronic central serous chorioretinopathy. This is another interesting case that we just published on retinal cases and brief reports. We described the use of photobiomodulation in a patient with 55 years old with a chronic central serous chorioretinopathy that lasted for 18 months. This patient had no response to epinephrine therapy, 50 milligrams per day for 10 months. And on FA, there was no leaking point that can be treated with a laser. So in these cases, we do a low-level light therapy with the same protocol of Dry AMD, so yellow and red lights, 1 session per week for 4 weeks, and then 1 session bi-weekly for 8 weeks. And these are the results. You can see baseline, you can see 3 months, the reduction of the 2 detachments, you can see 6 months, and you can see after 1 year, the complete resolution of the 2 detachments. In parallel, you can see also that this resolution of the liquid accumulation was also linked to an improvement, a recovery of retinal sensitivity on microperimetry. So, how can we conclude from this evening? That the preliminary results show that photobiomodulation using a highlight system is safe and well tolerated in patients with Dry AMD. The preliminary analysis 4 months after the first cycle show the efficacy of the procedure in terms of functional and anatomical data. Currently, a prospective interventional randomized sham-controlled double-masked multicenter clinical trial, including patients suffering from Dry AMD, is currently ongoing across the 7 centers that we showed before. Of course, longer follow-up and the risk of conversion to wet AMD and geographic atrophy represent important points to be investigated in the ongoing trial. We expect to have the final results for this study in spring 2025. Another retinal disease, so central serous chorioretinopathy, is currently under investigation. I show you a representative case report, but in the InfoRetina meeting in the next few weeks, a board of experts is expected to join a table in order to design a randomized clinical study with this new indication. Thank you.
So actually, I have one question for you, Prof. I think it's something that we encounter quite frequently, because just like any new technology, I think always the first question that comes in mind from doctor's point of view is the safety. So could you elaborate more on the safety on LLT?
If we talk about the treatment in dry eye and ocular surface disease, there are zero safety issues. Patients stay with eye closed with the red light for 15 minutes, and they have an immediate relief of symptoms. They have an immediate sensation of fresh, of positive feeling in the eye, tearing, immediately tearing. So with dry eye, the sensation is immediately relief from symptoms. It is incredible. Patient just after the completion of the session can report this fast improvement. And the dry eye patients are very difficult to be treated. For the dry AMD, so for the retinal point of view, we use, as we saw, the two phases of treatment. And for 1 minute with the yellow light and 1 minute with the red light, patient has to keep the eye opened with a pulse light. But the protocol was studied after several experimental studies in order to provide to the retina an amount of light that is not harmful for the retina. In our cases that we published a few months ago, that are about 75 patients, we have all patients were fully compliant. We had no signal of burns, of course, in the retina, no alteration of microperimetry. We had less conversion to wet AMD compared to sham group. I mean, in the sham group, we found a number of patients who converted to wet AMD that was statistically significantly higher than patients who receive photobiomodulation. So the treatment not only does not increase the risk of conversion to wet AMD, but decreases this risk. So the tolerability is good, and we know it from the studies on dry eye, but also there are no safety issues in terms of damage to the retina or conversion to wet AMD. Of course, we need longer follow-up, we need larger sample sizes, but now the eyes treated are more than 200 with any issue of safety. So I think that you can treat with safety whole patient with retinal disease with no fear, because the protocols have been developed according to experiments and according to previous safety studies that were concluded with positive results.
Recently, Espansione released their 6 months interim data on the Lightwave 1. So it is a study about eyelight in dry AMD treatment. It was released in Euretina, but it's not released yet in Asia Pacific region. So this is the best place and time to release the data at APVRS in Singapore. The treatment landscape for AMD now is actually very limited. If the patient has dry AMD, you can't do much. You can only start the AREDS2 supplementation, and basically you just wait for them to convert into wet AMD, where it's either anti-VEGF or maybe even surgery. So there is huge gap to be filled. And I think eyelight really fills up that gap because it treats dry AMD in the early and intermediate stage, and it prevents progression and prolongs the conversion into wet AMD. So eyelight definitely fills that role well.